We'll be performing endoscopic, state-of-the-art spine surgery here in just a few moments. We're going to get started. Our patient is awake on the operating table, prepped and draped, ready to go. And she comes to us from Texas. Good morning, this is Dr. Deukmedjian. Can you hear me? Can you hear me? All right. That's my hand on your back, okay? This is the left side. Everybody agrees? This is the side we're doing. And we're going to treat L344551. She basically has a lot going on with her back. And this is a good opportunity for me to talk about that because people that come to us with back pain, there are about 32 different causes of back pain. And we're going to be fixing 3 of those causes with the laser surgery today. Then we're going to do a rhizotomy on the opposite side, which treats facet pain, inflammation pain. And that's going to treat an additional 3 sources. So she'll be getting 6 sources, plus she already had some kyphoplasties done for spinal fractures. That was done yesterday. So that's where we fill the fractured bone with cement. So she had 2 more sources of pain that were addressed. So a lot of people don't understand. Back pain it's not just your back that hurts. It's very specific joints, very specific muscles that can hurt. And we treat those specific causes. That's why we're successful at eliminating back pain, is because we identify the very specific source. But after we fix the back pain, if somebody goes out and if you've ever watched Fail Army on YouTube, it's basically people doing stupid things like jumping off bicycles, jumping off the roof, landing on their back. You know, if we fix your discs and then you go out and do something you're not supposed to do and injure a different part of your back, obviously you can have back pain come back again, but it won't be from necessarily the same source. It could be from a different area. So the point is that there are many causes of back pain. When people come to us, we identify their specific cause that they have at this time. We fix it. And then if they end up developing back pain in the future, most of the time it's because they have pain coming from something else that we haven't treated. So the back has a lot of different causes of pain. All right, we're going to get started. Remember our deal, okay? If you have pain, you just say ouch, and I'll give you some more numbing medicine, all right? All right. That's just the numbing medicine going in. It's going to be a little burning and a little discomfort, but that'll go away in a few minutes. Okay, just relax. You're doing great. I'll let you know if there's any problems, okay? Otherwise, you just relax. All right. 6 cc's injected. So we're going to get started, and what we're going to do here is we're going to first access the herniated discs at L344551 on the left side through what's called a transforaminal approach. And to do that, I'm going to use a little spinal needle. Shot. Okay, let's go lateral, please. Now, this is not a surgery. I may make it look simple at times to do, but it's actually very difficult to do, especially in a patient that has scoliosis and listhesis. And most of our patients that come to us with advanced age, they all have twisting of their spine. And so I have to work around that. Table should go down. Table's too high, bring it down a little bit. Shot. All right. Now she does have scoliosis, obviously at L5S1. We need to adjust the lateral view. Try that. Let's see if that makes it better. That is better for sure. I don't know if it's completely better. Let's do a little more. Let's see what happens. That seems to be a little worse. Let's go the other way. Shot. Let's see if we go a little more. Let's see if we can bring the back of the sacrum. Shot. keep going. Try one more. I think it's getting worse, but let's see. Go back the other way. And do we have our MRI?
Yes, sir.
Let's take a look at 5-1. What do we have there? It doesn't look like. Keep going. Keep going.
That's it.
See if you.
The other side. Good. That's it.
Well, bring me to the middle. I want to see the middle. That's as far as it goes?
Yeah.
Okay. And there's no other sagittal view?
No, sir.
Right. Well, we needed to do something, so let's keep going and see when we can find the right spot. It's very important if you do this type of surgery that's image guided using fluoro. No, I think that's worse. So we need to go the other way. It's very important that you line the spine up as close to normal as you can get it. I mean, that's definitely better. But let's see if we can go a little further and make it even better. I don't know. To me, that seems worse. Let's see if we can wag and get the bottom of the L5 end plate lined up properly. So before I really get close to all the nerves in the spine, I really want to make the spine as anatomically correct on the x-ray machine. I really want a lateral view, a true lateral, and I want an AP view that I can rely on for navigation because I'm using the spine to navigate. Shot? I think, yeah, let's move north a little bit with the fluoro. Just a little bit. Let's see if we can do better there. So our end plate of L5 is at the bottom is not looking good. Let's see if we can line that up better. You're going to have to wag to do that. Now our patient also has osteoporosis. That's a little better actually, but I think we need to do something with this. Yeah, I want that end plate lined up. The L45 disc looks pretty good, but the L5S1 doesn't. Try wagging. Are you able to see that end plate? Yes. You see how it's not lined up properly? So you just keep going until you get it lined up. That's actually, it looks better to me, but then I think we're off on the orbit, the orbital part. How are you doing? Are you comfortable? Yeah. One more time, it's a little blurry. It's really hard to say. I wonder if we've overcorrected. Let's try going back the other way. Shot? That definitely looks better. Let's try a little more and see if we can make it a little better. Shot? That's probably as good as we're going to get it right there. I think that's pretty good. That's pretty darn good. Lock it in. So, I just want to emphasize how important it is. If you're using the fluoro to navigate for a procedure on a person's spine, you must take your time before you do anything, really. We put the needle in, but we haven't gone very far. I just want to make sure we're heading in the right direction with the needle. But before you get anywhere near the spine, you need to make sure the spine is lined up properly. I think we could, I want to say, should we wag just a little bit? I wonder if we can get that end plate a little bit better. Let's just try a slight wag. Maybe bring my side south a little bit, just see what that does, but be ready to go back to the original. Hard to say. I'm not convinced that that's better. Let's go back. How many degrees are you wagging?
1 or 2.
Yeah, that's the right amount. Monica, any suggestions? I think that's probably good right there. Yeah, that's the best right there. I agree. Let's lock it in. All right. Now it's important, obviously, your patient doesn't move. Are you comfortable? You feel something there, Shot? So you don't want your patient to move, because what's going to happen if they move on the table is they're going to change the relationship between the fluoro and their body and their spine, basically, which you don't want changed. You want that fixed. So you want them comfortable while you're doing what you're doing. Otherwise, they're going to start moving around. Shot? 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 Are you comfortable? Shot? I can feel myself going past all the arthritis in the facet joint. Are you still comfortable? Shot? Let's go AP. So we're in the foramen at this point. I want to make sure we're close enough to the disc. And by the way, the L5S1, which is the one we're starting with, is always the hardest to get. It looks good. Let's go back to a lateral view, please. As a matter of fact, there's only a handful of endoscopic spine surgeons in the world, probably 10 to 15 of them. And every one of them, they don't even do L5S1. They won't do it because it's just too difficult to do. I think it's worth trying. I've only not been able to do it once or twice in probably about 1,000 of these surgeries. Shot? So our trajectory looks okay. It doesn't look great, but we're about to find out just if we're in the right spot. Any discomfort? Huh? Nothing? What did she say? So her right, nothing down her leg? That's what I really want to know. Anything going down her leg? What'd she say? Where? But that's the tingling she always has, or is it new? That's the tingling she always has. Yeah, that's right. Shot? We want to know if she feels something different. I think we're a little bit higher than I want to be. Very, very close. Shot? We're just a millimeter higher than I want to be. And that millimeter can make all the difference in the world. So we're going to pull back for a second and try to redirect. Shot? Now part of the problem I'm dealing with here is that her facet joint, Shot, is really enlarged. And I need to navigate around it. Shot? But it's deflecting my needle at this point. And so I'm going to try a little different trajectory. Shot? Shot? It's a little higher than I want to be. Yeah, sorry about that. Shot? Just lay still. You're doing really good. Everything's okay. Shot? 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 Where do you feel that? Huh. Where? Just lay still. Tell us where you feel it. What'd she say?
Say again.
You feel it in your back or down your leg?
Your leg.
No, at the top of her leg. Where?
Where your leg. Where place?
Where do you feel it? In your back, but not down your leg.
It's in your leg. You feel in your leg?
Turn the leg squeezers off for a moment. Let me know when they're off. All right. I need to know if you feel it here or if you feel it down your leg, okay? Where do you feel that?
Your leg? Huh? It's in your leg. Yes.
Where in her leg?
On the top.
That could be facet. That could be facet. I need to know if it goes past her knee.
Down to your leg.
Ask her if it goes down to her foot or her calf.
Your foot.
Does it stop before her knee? Let's get an AP. I'm really not even near the nerve, so I don't understand how it could be going down her leg. I'm at the facet. I'm at the facet joint. Yeah, back to a lateral, please. There's no way it could be going down her leg. You see what I'm saying? So I need you to listen to what she says and tell me if... Yeah, but just say below your knee or not. No.
Just let me know if you feel it down your leg.
Are you back in the same position?
Yes.
Shot?
Just yes or no? No.
Yeah. Where? But where is it going? Is it in your back or down your leg?
Down.
Down to your foot?
The foot, yes.
Shot? Shot? Is it in your foot?
You feel in your foot? Yes? Yes.
I mean, we're not even, it's impossible. We're not even in the foramen. What'd she say?
You feel in your foot now? Big toe.
Yeah, but it's where she's had it from the beginning. Is it different? Is it different?
Is it something different, something that you
Shot.
feel now?
Is it something new?
This is a different sensation for you or the same that you have all the time?
Shot.
Huh? Kind of the same.
Yeah, of course it's the same. Shot. Relax. You're doing great. Shot. AP. Kind of hard to tell. You need to bring the fluoro. You're not really centered at 5-1. Bring it towards you or something. Let's just see. That is, I think, better. So let's do a little discogram dye and just see if we're in the center, if we're in the disc, which I think we are. I just want you to stay where you are. Are you comfortable? All right. You don't feel any pain? Shot? Yeah, it looks like disc. Let's go lateral real quick to verify. Huh? Yeah, I think so. Just take the lateral when you can. No, let's get a real lateral. There we go. All right, good. We're inside the disc. So now we got to get 4-5 and 3-4, which should be, I won't say it, not as challenging. We're going to make a little incision. You feel that? Huh? She does. Is that uncomfortable? Well, that should have made it a little better. We did another 3 cc's of local. All right, so we're in the L5S1. Now we're gonna go for the L45. Are you lined up at 4-5? All right, so let's get 4-5 lined up. Just relax, you're doing great. Take a shot. I wouldn't move anything yet because she was breathing. All right, maybe try to wag it a little bit, one way or the other. Let's get the end plate of 4 lined up. You want to look down the 4-5 disc, basically look straight down it. I would bring your base more north. So you went north, which is good, but I don't think we can see down the 4-5 that well. All right, so while she's getting the fluoro shot lined up, by the way, if you notice, which I think you have, put a little pressure here, please. We are adjusting the fluoroscopy, which is what we're using to navigate. We're adjusting it every time we change levels. That doesn't always have to be that way, but you have to make sure that you can see the end plates line up. And you can see the pedicles, you can see the foramen. That's, I think, better. I like that. Let's leave that. I think we're okay there. And in a lot of spines that aren't twisted, you can usually get into the disc herniation and fix the herniation through a transfemoral approach without having to move the fluoro around a lot. But in some patients, you have to move it because their spine is twisted a lot. And everybody's twisting or scoliosis of their spine is different. So you just have to be prepared, shot, to move your fluoro around a little bit. All right. Shot. Once again, we're going to go through the foramen. Shot. Into the disc. Shot.
You feel something in your leg now?
Shot. It's a little lower than I want it to be. Shot. Shot. Are you comfortable? Shot. Huh? All right.
Let me know you feel something in your leg.
Shot.
Tingling or something.
Shot. Shot. Let's get an AP to verify. Are you comfortable? All right, looks good. Let's go to the last disc, which is the 3-4, very collapsed. So, for those of you wondering, what are we treating here? There's 2 things we're treating: leg pain or radiculopathy, and then back pain. That's the two things that Duke laser disc repair treats: back pain and leg symptoms like numbness, tingling, weakness, or pain down the leg. All right, we need to line up 3, 4. It's not terrible, but I think we could do a little bit better. See what you can do. So why do the Duke laser disc repair? When you have back pain from a herniated disc, or if you have leg pain from a herniated disc. Herniated disc is the most common reason people get, in my opinion, people get back pain and leg pain. Shot? Now you're going to have to move your fluoro further north. Or you're going to have to wag. I think you're, I don't know. Let me see again. I just can't see the pedicle of 3. I mean, the pedicle of 4 looks pretty good. Let's just try wagging a bit.
Can I try the other direction?
I would try something. You need to try something. That's, I could see the pedicle of 3 better, but now I can't see the pedicle of 4 as well. Let's go back a little bit. That's probably going to be the best we can do. Let's just see how that does. So once again, we're moving the fluoro again relative to the patient's body because we want to basically what's called optimization, or optimize our view while we're going into the foramen and the disc. If you don't take the time to do it right, Shot, then you're going to end up being in the wrong place, which could be devastating. Shot?
We have a question.
Yes.
One reviewer is
John?
wondering, how can this procedure fix the complications caused by scoliosis, lordosis, and twisted spine?
Shot? That's a great question. So the viewer asked, how does this Duke laser disc repair fix complications caused by scoliosis, lordosis, kyphosis, or I think, what was the last one? Listhesis?
Yes.
Yeah, so the first thing that a lot of people don't understand is that scoliosis itself doesn't cause problems unless it's very, very, very advanced. And most people that have symptoms of back pain, it's not from the scoliosis. It's not from the kyphosis necessarily, and it's not from the listhesis. It's actually from the herniated disc. So if you can fix the herniated disc, you can fix the back pain, the leg pain, without treating the scoliosis, kyphosis, listhesis. Let's get an AP. Where do you feel that? Where does she feel that?
Where you feel that?
Huh?
You know how to do it?
Where do you feel that?
Back on your leg. Your leg. Your foot.
All right, back to a lateral view. So what I'm getting at is, though everyone believes, oh, I've got twisted scoliosis, I got to have my scoliosis fixed, or I've got kyphosis, I got to have my kyphosis fixed, or I got listhesis, I got to fix the listhesis. You don't. What you need to fix is the cause of your back pain, and it's not the scoliosis, it's not the kyphosis, and it's not the listhesis. It's literally the tear in the back of the disc where the scoliosis, kyphosis, listhesis is that's causing the back pain. And it usually isn't the entire spine. It's just a part of it that's causing pain. So you don't need to treat the entire spine. Where do you feel that? Where? Where do you feel that? This is where I need you to help me.
You feel your back on your leg. More on the left.
Is it still there?
Yes.
Is it still there?
You still feeling your leg? Yes.
Yeah, we're not anywhere near the nerves. Well, she has leg problems to begin with. So just lay still. Don't put your arm over here. Remember, we had an agreement. You don't move. We need a nurse over here helping with her arm. Are you okay? All right. So whoever asked the question, the answer is you don't need your scoliosis fixed. You don't need your kyphosis fixed. You don't need your lordosis or listhesis fixed. What you need is you need your pain fixed. And it turns out that we can fix the pain without correcting the scoliosis, without correcting the kyphosis, and without correcting the listhesis. And that's because we're going for the source of the pain, which is the herniated disc. Shot? How is she? Just in her back, Shot? On her butt? Yeah, we need it. You need to communicate that a little bit better to us, okay? That's your job, Shot. That's what we need you to do. Lay still and tell us where you're feeling discomfort. I mean, that's pretty good. But I think I can see a double shadow on the facet. I wonder if we can't make it a little better. Where? Yeah, Shot. Shot. Yeah, I know. It's not your normal pain because we're giving you a pain you've never had with this needle. I need you to give me a little better view of 3-4. I would move your base more north, I think, because she has scoliosis. It's pretty bad. Shot. That in your back again? All right. So that's just referred pain going from her facet joint down to her buttock. We know all about that. Shot. That doesn't worry us too much. Shot. Where do you feel that? Good. You're communicating very nicely now. That's what we need from you. Shot. Shot. You're doing great. I'll let you know if there's a problem, okay? Just lay still. Her, she's starting to tighten up a little bit. Shot. Like when, so I know we haven't done a lot of these together, but when the patients have pain, their muscles spasm, and then it closes the disc. It makes it harder for me to get inside. So this would be the time if there's anything you can give that's not fentanyl, because I want to do a discogram, but maybe something else that would dissociate her, you know. But we're good now. Now I'm going to do our discogram because we're in. Go ahead and get an AP. So I want to do the discogram at this point. So let's keep her awake. All right. So it's been challenging to do, but we've now been able to get into all 3 discs, the 3 discs that we're targeting. And you think that's her aorta over there? What is that? I mean, wow. You see that? Do you think that, I mean, that's probably the aorta, right? It can't be a rib. So that thing is calcified. Yeah, majorly. All right, but I'm happy with our needle position. The only one I was questioning was the 5-1. I wasn't sure. because the twisting that's going on at 5-1 and at the pelvis, sacropelvic region. But I've done a little bit of dye earlier, and I'm in the disc, so I'm very happy about that. So what's causing her pain in her leg, what's causing her back pain is for sure the disc herniations, the 3 disc herniations, L3, 4, 4, 5, 5, 1, specifically the annular tear and where there's what's called the interposed nucleus, which is the nucleus pulposus sitting in the outer annulus causing inflammation. That's where the back pain comes from. She also has a component of facet pain, which I confirmed before surgery on the right side, probably due to her scoliosis. She's probably loading those facets, causing more inflammation and pain in them. So we're going to do a rhizotomy on the right side at 3, 4, 4, 5, 5, 1 when we're done. Just because I think the facet joints are also causing her back pain, not just her discs, but also her facet joints. And she already knows about that and has agreed to it. Are you comfortable? All right, we're going to put you to sleep in a few minutes, but I want to do something first. Will you let me know if you feel any pain, okay? Will you let us know if you feel pain? Okay. How bad is that on a scale of 1 to 10? 10. Is that where you typically get your back pain? Is that the area that you get your back pain? So concordant, L5S1, 10 over 10. We always take the higher number. All right, is that better? That's not enough. All right, I'm sorry. Yeah, I'm sorry. We just had to test the discs. Well, the good news is we found one of your painful discs. So we just did a test on the disc to see if it's causing her typical pain that she gets every day. We call that concordant, spelled C-O-N-C-O-R-D-A-N-T. When we find the typical pain source that the patient has every day and we can reproduce that pain through either a discogram or another type of procedure, we call it concordant, meaning that it matches the patient's daily pain. So she has concordant pain at L5S1. Are you better? All right. We're going to check 045. Here she is jumping off the table. How bad is that on a scale of 1 to 10? 10. 10. L45. Is that where you get your pain typically? You don't have that kind of pain normally? Not that severe, I understand that, but is that the right location in your back? Yes, so concordant at L45, 10 out of 10. So she said, no, my pain isn't normally that severe. But what happens with patients is they end up changing their entire lifestyle where they stop going out and walking and doing the fun things in life, like that require bending and twisting and activities that require the movement of the spine. They start guarding those painful discs by limiting their activities. And that's one of the reasons we do the surgery, is to give people back their quality of life where they can actually go out and do the things they want to do. Now, she can't do those things right after surgery because she'll re-injure her disc. And I have patients who have done that. They've gone out, they're feeling great, and within a week or two of surgery, they're doing things they're not supposed to do, like lifting heavy things, twisting. I had one patient who started gardening the next day after laser surgery, and he was taking bags of mulch out of his truck and throwing it onto the ground so he could mulch his bushes, and he felt a pop right after surgery the next day. And I said, he came back in and we got an MRI, he re-herniated, and he said that he was feeling so good he thought he could do that. And so it's important that once you get your disc fixed with the Duke laser disc repair, you understand it takes a year to fully heal. So you really want to be very delicate on your back for a full year. Or if it's your neck, the same thing with your neck. Are you comfortable? All right. How bad is that on a scale of 1 to 10?
10.
Is that where you typically get pain?
Is that where you typically have your pain?
All right.
Yes, that is.
Yeah.
That's
So that's a 3/4 is concordant, 10 out of 10. You can put her to sleep now. I want you to count from 1 to 100 out loud. Count from 1 to 100. And you got to do it with a Texas accent. Go lateral, please. From 1 to 100 out loud. And when you wake up, we'll be done with your surgery. So, a couple of notes. Number one, importance of having your fluoroscopy lined up properly with the spine so that you your pathway from the outside world to the disc herniation is anatomically correct, that you're not damaging anything you shouldn't be damaging. Good job. Yeah, let's keep it there. And we're going to start with L5S1. So you can see the herniations in the back of the disc. You can see the dye kind of outlining the back of the herniation at L5S1. Let's get these wires out of the way. They should be up here. And we'll get started at L5S1. Shot? Okay. So if you could somehow, I don't want you to move too much, but look in the back of the L4-5 disc too. You can see the herniations. You can see them clearly at 4-5 and 5-1. 3-4, you don't really see it on the lateral view very well, but they're there. You can see them on the MRI. All right. So at this point, I've got to make sure that my guide wire is in the L5S1 disc space. Shot. And that shot. I'm able to take the needle out. I don't want to take the needle out over the guide wire unless the guide wire is in the proper position. Shot. That looks good. All right. Don't try this at home, folks. Shot. Just want to make sure my guide wire is still in place. It is. Good. So Duke Spine Institute is the first place in the world to do an endoscopic annular repair, or debridement. Debridement basically is really what it is, not a repair but a debridement. And we call this the Duke laser disc repair. We're the first people in the world to publish it. All the other surgeons talk about removing the herniation, but they don't talk about doing anything to the annulus. Yeah, this is where you want her to be a little deeper, if you can get her a little deeper, while we go through the foramen and into the herniation. So one of the things about the Duke laser disc repair is we are literally we're going to fix her back pain and the pinched nerves, which is the same thing a fusion surgery done properly would do. If I were doing a fusion, I would remove all the bone in the back of her spine. I would open the holes. And we've shown these fusions online. We've shown them over the internet. They're probably available through Facebook if you look, or YouTube. But I've done 3-level fusions before. We could have done that on this lady. We would have the same relief of pain in her back because we're cleaning the 3 discs out and getting rid of them. We're fusing them. Plus, we would be unpinching the nerves that are causing her leg symptoms. We would do that with an incision this big. Literally, the incision on her back would be as long as this metal tube, okay? And the recovery from the surgery, the fusion surgery, would be months. This lady is getting it all done through a tiny little 7mm cut. We're going to repair 3 discs that would normally be fused, and we're going to have the same results as a fusion with respect to pain relief, but without the recovery, without the long recovery. Shot. Yeah. So she's uncomfortable. I'm trying to get down to the spine. And I have to get through past the facets and into the foramen. Shot. Yep. She's not making it easy for me. A lot of arthritis in here. Shot. I'm going to have to use the mallet. Shot. All right. You think she's pretty relaxed? All right. Shot. The more relaxed we can get her, the better. At least for this part. Shot. Let me know when you think she's a little more relaxed. Yeah, take your time. you know, at 5'1", I just don't want the guide wire coming out, but I need her muscles not tightening up on me. They seem okay, but you tell me when you're ready and I'll move forward. If we need to, we could also go to 4-5. But now that we've started 5-1, I'd like to finish it. So a couple of more things about the Deuk laser disc repair while we're waiting for our patient to go to sleep. Tiny incision, 7 millimeters, as opposed to a giant incision for open back surgery, which every other surgeon out there is going to try to do, is open back surgery. If this lady was having her scoliosis corrected, we would need to open her from all the way up here all the way down to here. And for what? The purpose, people don't come into the doctor's office and say, I have scoliosis, fix it. They come in and say, I have pain. I want to be out of pain. So the source of the pain is not the scoliosis. I've never found it to be the scoliosis. I've been doing spine surgery 23 years as a neurosurgeon. I was brought up believing that the scoliosis was the cause of the pain because that's what I was taught. And of course, as a resident in neurosurgery, you take what you're taught and you make that what you believe without really questioning it very much. But once I started doing the endoscopic surgeries and I wasn't fixing the scoliosis at all, I was just repairing the disc, and people were getting out of pain, their pain was 100% gone, I realized you could fix back pain from a herniated disc without treating the scoliosis. So that's when I started doing more of these procedures and looking at the results, and I found that it doesn't matter if the patient has shot, scoliosis, listhesis, whatever deformity they have, it doesn't matter, because the laser surgery can fix it. It cannot fix the deformity, but can fix the pain. Yeah, I think she's much better than she was. She feels more like things are moving easier. Shot. I just need to get into that disc. She's kind of pinching and advancing the guide wire a little more than I want. There we go. That's better. Shot. So I pulled the guide wire back, and yeah, much better. I couldn't do it without you making her more comfortable. So thank you. Yeah, no, I don't mind waiting. You know, whatever's safe for the patient, we do. But I'm just saying I wouldn't be able to do it without her being more relaxed. So I'm glad you were able to do that. So it's moving much better now. So if you're interested in doing this kind of surgery, it's very shot. That's it right there. It's very important that the anesthesiologist makes the patient comfortable. And the reason is simple. If the patient is in pain, they'll tighten their back muscles up. A lot of people don't talk about this, but it's 100% true. And if their back muscles tighten up, they're going to, you're not going to be able to get the into the disc. And you could end up hurting the patient. So we're in. The entire surgery, folks, is going to be done through a little tube. Okay, this is endoscopic surgery. So there's a lot of surgeons out there that say they do laser surgery, endoscopic surgery. They're lying to you. They don't. True endoscopic spine surgery is done through basically a 7 millimeter, what's called tubular retractor. Retractor just means it's a tool used in surgery that pushes tissues apart so the surgeon can get down to the part of the spine they need to operate on. This is a tubular retractor. And the endoscope will go down the tubular retractor, and I'll be able to see at the bottom of the tube, right inside the disc, I'll see the herniation, and I'll be able to remove it with a laser and instrument. It's called the pituitary rongeur. Okay? So now I'm going to put the tubular retractor over the dilator and get into the disc. And the patient is nice and relaxed right now, thanks to our anesthesiologist. Shot. All right, so the reason we're having some difficulty advancing the tube is only because the patient's arthritis. I can feel it. There's massive amounts of arthritis in her spine around the facet joints. Shot. And I always like to try to advance things without the mallet, but the mallet is necessary right now in order to advance the tubular retractor. Shot. Okay, that's good. Making a little bit of progress. Shot. Yes. All right. I just don't want to advance the dilator, which is the larger pencil-like metal thing that's already in there. That's already in the middle of the disc, which is where I want it. So now I have to advance the tubular retractor over the dilator without advancing the dilator. And I'm using my X-ray machine to look and make sure I'm only advancing the tubular retractor, which I am, and not the dilator. And I constantly check to make sure. Shot. She's a little more awake, which is not bad. I mean, it's not terrible. All right, so we're just about all the way to where I need it to be, which is about halfway into the disc. Yep, there it is. I can see the end of the tubular retractor. Now I'm going to get the dilator out, which we use the dilator to slide the retractor over. Shot. And there we are. Now, some people wonder what kind of doctors can do this surgery. And of course, there's lots of doctors that want to do this kind of surgery, but they shouldn't because they're not qualified. The kind of doctor that's qualified to do this is someone who's trained in surgery. Okay? And it's very important because this is a minimally invasive surgical technique. I'm not ready for that yet. I need the fluid adapter. And it should be done by a surgeon, okay? So be careful who you allow to operate on you. Endoscopic spine surgery should be done by a surgeon or someone trained in surgical technique very well. And if it's not, you could be setting yourself up for disaster. All right. Any other questions from our audience, Sean?
None others currently.
All right. Did our question from the person about the scoliosis, did I answer that for them?
Yes, you did.
All right.
Now, they did say that they only have current x-rays. What is the minimum they need to get reviewed for other conditions?
Yeah, so folks, when you're wondering, hey, I've got chronic back pain, all right? I got back pain that's lasts longer than 2 months. Okay, I've got back pain for more than 2 months. You really should get an MRI. MRI is the very best test. If you can't get an MRI because you have a contraindication like metal in your body, pacemaker, defibrillator, whatever, that's not compatible, then you need a CAT scan, CT scan of your lower back. So MRI is preferable, CT scan is next best. Look at this tissue right here. You see that pinkish color? Okay? I want to draw your attention to that. That is where, that's called granulation tissue, first of all, and it means new tissue that's formed during inflammatory processes. All right, laser? That's where the nerve fibers are that cause the back pain from a herniated disc. They're inside this pink tissue called granulation tissue. Let's go, laser on. Come on, Monica, laser on. Ready means we're ready to use the laser. All right.
We have another question.
Yes.
One of our viewers is wondering, is this procedure similar to a laminectomy?
So our viewer asked, is this procedure similar to a laminectomy? No. A laminectomy is an old spine procedure. You don't want it done unless it's done, as, in my opinion, as part of a fusion. A laminectomy is where the surgeon makes a cut in the middle of your back and exposes the spine and takes out the lamina. A lamina is a piece of bone in the back of your spine. Now the problem with laminectomy is, number one, it only treats leg pain, nothing else but leg pain. And That's only a specific type of leg pain. It has to be leg pain that from a nerve that's being pinched in the back of the foramen. Okay? Otherwise, a laminectomy won't work. A laminectomy is going to weaken your spine because you're removing bone from your spine. The spine is a stabilizing structure that supports the weight of your body and all the organs. And the moment you start taking parts of the spine out, the bony spine out, you're now weakening the spine and making it more susceptible to re-injury. So people who have laminectomies almost always end up needing more extensive surgery on their spine a year or so later after the surgery. So I don't recommend laminectomies at all. I was trained to do laminectomies. I've done many of them in my lifetime and my career, but they're a much worse procedure because they weaken your spine. So you don't want a laminectomy. Lamina means the bone in the back of the spine. Ectomy means to remove, okay? Laminectomy is removal of the bone in the back of the spine. This surgery you're watching right now, we don't remove any of the bone in the spine. That's one of the reasons we do this Deuk laser disc repair, is because no bone is being removed. Removing bone from your spine, whether it's a laminectomy, microdiscectomy, a fusion, whatever, they're all removing bone from your spine and weakening your spine. You don't want a laminectomy, folks. It's an old-fashioned surgery that doesn't work very well. It does not treat back pain, ever. Laminectomy is for treating leg symptoms, which is basically something called neurogenic claudication, which is weakness in your legs that happens with standing and walking. That's the only thing a laminectomy can help. If you have back pain, a laminectomy will make it worse. Pretty much guaranteed. So why do surgeons do laminectomy? Because they don't know how to do these other more advanced types of surgery. It's simple. One of the reasons we broadcast these surgeries is to show you the state of the art in spine surgery. Come on, man, you got to grab it. You want to see the state of the art in spine surgery? Watch what Duke Spine Institute does. We don't do robotic surgery because robots are not the state of the art in spine surgery. Robots are a marketing gimmick. It doesn't add any value unless you're not a good surgeon. If you don't know what you're doing in surgery, then you get a robot. And you pray to God that the robot helps you become a better surgeon. But robots don't make surgeons better. They may make their surgeries better, but they don't make the surgeon any better. I see a lot of robots being sold to hospitals in the news. Basically, think about it this way. There's a lot of very rich investors. They buy the company that makes the spine robot. They hope to increase their investment, which is nothing wrong with that. We live in a capitalistic society. So those investors spend $10 million buying a company that sells spinal robots, and then they go around and convince every hospital they need a spinal robot when they really don't. The hospitals buy the robots, and the investors turn around and turn their $10 million into a $100 million investment. It's a great return on investment, but you know, for a patient, they don't need the robot. It's useless. All right, here is the tear that's causing all the pain in the back, right here, from this disc. So this is the Deuk laser disc repair, the only surgery in the world that debrides the tear. A debridement means you clean it up. You're cleaning something up. There's debridements in the shoulder. There are debridements in the knee. There are debridements in general surgery when you debride a wound. And now, for the first time ever, we have a debridement of a herniated disc. Specifically the annular tear. Not the whole disc, just the tear in the annulus. By the way, that's the end plate over there of S1. And there's the end plate of L5 over there. The blue stuff is the dye that we put in at the beginning when we did the discogram. That's not naturally found inside the disc. Stand by. Okay, we use the dye to see degenerated nucleus pulposus. It helps me find the parts of the disc that need to come out. It guides the surgeon. Just like we use the fluoroscopy or X-ray unit to guide me to the right spot on the spine so I could do the surgery safely. We use the blue dye to help guide me to take out the parts of the disc that need to be taken out. Take it. To be honest with you, when I first heard about this laser spine surgery technique, it was back in 2005. And I thought, actually probably 2004, and I thought it's just a gimmick, you know, like so many other things. It's just people trying to get rich off of some idea that doesn't really add any value to the patient. All right, and I was guilty myself of discrediting it initially, but I decided to go see what it's all about, which I've done as well for robotic surgery. And when I saw the surgery done the first time, I was impressed with the small incision. I was impressed with the view of the inside of the spine, you know, how good the view was and how everything was anatomical. See, in surgery, it's important for a surgeon that everything is anatomical, meaning that you can understand the anatomy in 3 dimensions and relate to it and what needs to be fixed. You can actually do that and see it on a very magnified and illuminated level. And that's what endoscopic surgery provides. So when I actually saw the surgery done and I saw the patient did well, I watched a few more. I watched 3 of them. I was very impressed with the results. But the surgeon that I was watching was doing the surgery for leg pain. They were only treating a herniated disc pinching a nerve, causing the patient to have sciatica. And when I started doing endoscopic surgery, I did it for the same reason, mostly for leg pain. But then I asked my patients always about things, you know, do you have any complications? How's your back pain? And I was amazed to hear that when I started to clean the annulus with the laser, this tear, when I started to clean the tear with the laser, that their back pain went away as well. And so then I started focusing more on the tear with the laser. And our success of getting rid of back pain just got better and better and better. Of course, we got rid of the leg pain too, but we also got rid of the back pain. And that's when I realized how important that tear was to eliminating back pain. You have to get rid of the annular tear and the herniated disc stuck in there that's causing all the inflammation. It's the inflammation that causes back pain in the annular tear. And the way you get rid of the inflammation is by getting rid of the herniated disc that's stuck in that tear. It's the herniated disc that's actually causing the back pain. And it's doing it indirectly through inflammation. It's kind of like a little thorn stuck in your fingertip, right? If you're out in the garden and you get a piece of wood or a piece of thorn in your finger, it starts to hurt. And the reason it hurts is inflammation. You see? It's not the thorn itself that hurts or the piece of wood that hurts. It's the actual body's response to the foreign body that's inside your skin, inside your body. Your body is attacking that thorn, that piece of foreign matter. It recognizes it's not supposed to be here. So it attacks it with the inflammation, with your inflammatory system. And it's that inflammation that they're starting to say now is the cause of people dying from COVID-19. They believe it's caused by something called cytokine storm, which is a very aggressive inflammatory response to a foreign body, which is the virus, not supposed to be there. Well, this is your disc's inflammatory response to the herniated nucleus pulposus. That's not supposed to be there. Standby laser. So it's happening on a very small level, like 5 millimeters, 6 millimeters in the back of the disc, but it causes immense pain and discomfort for people. And that's what we fix with the Deuk laser disc repair. This is the only place in the world you can go to get the Deuk laser disc repair done. Deuk Spine Institute. We're the inventors of this technique, And we've been doing it now for 15 years. And we've had the best results in terms of elimination of back pain in the world, with 0 complications to date. Look at that herniation right there. Oh, broke. I'm going to try to get the rest of it out. So how did the herniation end up getting shoved in? Oh, just can't seem to grab the whole thing. And the red stuff is blood. Yeah. Chicken or Italian? Yeah, it is important. What does our anesthesiologist want for lunch? Italian, there it is. Oh, she's asking about my sandwich. All right, what do you want? I want chicken for mine. What do you want? You want Italian? You like Italian subs? Or you want a chicken Philly? Chicken Philly cheesesteak? Huh? Which one, Italian or chicken Philly cheesesteak? He wants a chicken Philly cheesesteak too. Yeah. All right. So why do we have a little bit of bleeding? Because we've taken the herniation out. It's decompressed the veins, the epidural veins. Once you get the pressure off the veins, they start to bleed a little bit. This is a very small amount of bleeding. It's microscopic. It wouldn't even be noticed. It'd be like a diabetic person who pricks their finger to get a little bit of blood, a drop of blood, in order to test for diabetes, you know, when they do the finger prick. That's how little amount of blood we're talking about. So less than a cc. Very, very small. All right. Think we're just about done with this level. And look at that tear in the annulus. It's just so scarred up from years and years of inflammation. That's what we're dealing with. You know, if people get their disc herniations fixed sooner, then they're going to heal better, quicker, easier. And they don't have to live with the pain their whole life, or however many years they live with it. That's why we want to get the word out, folks. We want people to know about this new technology that's available.
We have another question.
Sure.
One of our viewers is wondering, can you be born with herniated discs?
Can you be born with herniated discs? Okay, that's a great question. I've never been asked that before, but I think I can answer it for you. The answer is only, okay, so herniated discs are a result of trauma to the spine. Trauma. Trauma means like that your bones were squeezed together forcefully and twisted usually in some fashion. So the bones were twisted and squeezed together. And what that does is it tears the annulus, which holds the jelly in the middle of the disc, and it also puts pressure on the jelly, so the jelly wants to squeeze out of that new tear that was just made through trauma. Does that make sense? So it requires trauma. Can you be born with it? In other words, while you were coming out of your mother's womb, was the surgeon too forceful in grabbing your legs and pulling? Absolutely, that can happen. I don't think that's ever been documented or published before. And the reason, obviously, is babies don't complain of back pain until they learn to talk, usually until they're older. But yes, I've seen very young people with back pain. Cake? That's it. We're done with this level. We'll go to the next one. Standby scope. Watch it. All right, let's get this out. Yep, perfect. Nice job. So we're going to take the tube out from the first disc that we've just fixed, and we're going to move on to disc number 2, which will be the L45. And remember, we've already tested all 3 of these discs that we're repairing today And all three of them cause pain, horrible pain for this patient. All three of them are painful discs. We know that based on the results of the discogram. Hold on. All right, you can come in for a lateral view. Will you pull this down a little bit? All right, so I'm putting a little bit of pressure on the paraspinous muscles. Yep, nice job. And the reason we do that is that we're not getting any artery bleeding, but we are going to get some vein bleeding from the muscles. So we want to make sure that the muscles have pressure on them so that the veins close and don't bleed. I want to avoid a blood clot within the muscle. And, you know, it's impossible to completely avoid any blood in the muscle, but you want to minimize it as much as possible. So in an ideal situation, there's zero blood in the muscle after we pull the tube out. And that's probably what we get. You know, we get close to zero, maybe 0 to 5%, 95% of the time. Once in a while, we get a little bit more blood in the muscle, and that causes a little blood clot to form in the muscle. It's called an intramuscular hematoma. And what that's going to do is it's going to, we need a better view of L4-5. You got to line it up on 4-5. What that's going to do is it's going to cause, basically, as the blood clot breaks down over 4 weeks in the muscle, it's going to release hemosiderin, which is going to cause some inflammation in the muscle. So basically, the more blood clot in the muscle there is at the end of surgery, the more pain the patient will have after surgery while they're recovering, and that pain can last months if there's a large enough blood clot. So we try to avoid that by putting pressure, and you want to apply pressure for about 4 minutes just to make sure there's no blood clot. All right, so we're going to get started on the next disc, which would be L4-5. You can see we're doing all three discs through one tiny little incision. Shot? I do that whenever I can. It doesn't always work, by the way. Shot? But it looks like it's going to working today. Shot? All right, that looks good. So I'm going to go ahead and get the needle out, leave the guide wire in. Shot. Now, for those of you who've watched me do these surgeries before, you notice with this surgery in particular, hold this here, that my trajectory seems to be a little bit higher. I'm coming in from a higher trajectory than normal. And the reason for that is because of her pelvis on my side is a little higher, okay, than normal. Shot. As you're doing the advancement of the dilator, she's starting to respond a little bit. You want to make sure, shot, that your guide wire stays anchored. And you really don't want to put a lot of force on the guide wire. Take your time. Let me know when she's ready.
We have another question.
Sure.
One of our viewers says, I had a laminectomy and foraminotomy 9 weeks ago. I have a bulging disc, but they didn't touch it during the surgery. Is it okay to leave these alone, and how long will it be until it starts causing me pain?
So one of our viewers is watching. They said they had a laminectomy, foraminotomy 6 weeks ago?
9 weeks.
9 weeks ago. And they have a herniated disc as well, but that they didn't touch the herniated disc. So they want to know, when is that going to start hurting them or cause problems for them? If it will, when will it? So to answer your question, if you don't have pain currently, but it could be because you're taking pain medication, but let's say you stop your pain medication, just theoretically, and let's say there's no pain in that area at all, then that means that herniated disc is not causing pain. It's not causing back pain, okay? So if you were to stop your pain medication today, if you were, doesn't mean do it. I'm not telling you to do that. I'm just saying, theoretically, if you stop all your pain medication and you go out and you do normal activities and you have no pain in your back at all, then that herniated disc is not causing you back pain. Does that surprise you? It shouldn't. Most herniated discs don't cause back pain. Only a small percent do. Maybe, you ready? Maybe 5% of herniated discs actually cause back pain. So it's not a large number. Shot? But of course, it turns out to be, millions of patients. We know that there's many, many patients with chronic back pain. All right. So, could that herniation cause pain for you? Absolutely. Is that my shot? Yes. All right. When? We don't know. It could be never. I hope it never does, for your sake. But chances are, because you've had a laminectomy, and they've just destabilized that part of your spine, the chances are that disc is going to become painful for you. If I had to bet money, I would bet that that disc will be painful. It's just a matter of time. Now when? It's impossible for me to predict, but if I had to take an educated guess, I'd say within 12 months, shot, it will be painful. Now the good news is you don't have to have a fusion to fix it. You can have the exact surgery we're doing right now, the Duke laser disc repair. We've had many patients come from all over the world that have had laminectomies. They have a herniated disc that wasn't fixed during their surgery, and they come here and we do a Duke laser disc repair and repair their herniated disc and get rid of their pain without doing any fusion. Fusion will be the alternative if you wanted a fusion for some reason. Shot? So to answer your question, you have to be off all your pain medication. And once you've been off all your pain medication for about 4 weeks, then assess yourself. Do you have back pain? And if the answer is no, then your herniated disc is not causing back pain at this time. Then the next question is, will it ever cause back pain? And the answer is most likely yes, it will. And when would that happen? We don't know. But the more active you are, the more likely it's going to become symptomatic and cause pain. If I had to guess, if you're an active person, I'd say within 6 months to a year, you'll get maybe without pain, but then you're eventually going to probably get pain there. Normally I don't guess, but you're asking me to guess, so I'll guess. But that's what we call the natural history. Natural history means that's what naturally will occur in time with that condition, unfortunately. So it's better not to get a laminectomy. All right, now we are inside the L45 disc. Once again, you can see how grungy it is. It's been damaged, and it's been influenced for years by chronic inflammation. These are all pieces of chunks of herniated disc that we've shoved back into the disc space as we enter the foramen with that dilator. Remember, we have to go through the tear, and we push all these herniated pieces back into the disc. And you're collecting them, right? Sure am. Yeah, so we're collecting them, and we're going to end up sending them to the pathologist. Wow, look at that. That's just a chunk of scarred up disc. So we're going to get our laser in because the laser is really good at dealing with scarred up herniations. Little bit of end plate to the right. There's the herniation and tear. Any other questions?
None currently.
All right, well, for those of you who know my surgeries, you know I like to memorialize things that are happening in life. I don't talk politics, laser. But we did just come back from Portugal. The World Championship in go-karting was held there. My son represented the United States. Arias is the ranked #1 go-kart driver in the United States this year. And we didn't do as well as we were hoping, because he had to basically learn how to drive a brand new go-kart with a different engine and different tires. And if you know anything about racing, you understand how important the engine and tires are on a go-kart. Basically, in 4 days of practice, he was able to learn how to drive the go-kart, and he was one of the fastest drivers in the world, one of the top 10 fastest in the dry. But then Portugal did something it's not supposed to do, and it rained. And we've had zero experience with that engine and tire in the rain, and it wreaked havoc on him. He tried his best to figure it out in literally two warm-up sessions right before qualifying. So he had literally 2 10-minute sessions in the rain with that engine and tire package, completely new and different, whereas everybody else had been driving it for many, many years in the rain. In particular, the British drivers, who have a lot of experience driving in the rain with that package. What's remarkable is that in 2 practice sessions in the rain, Arias was just terrible, literally terrible. He ended up qualifying in the rain, in the wet, 56 overall in the world, and which meant he started every race 23rd, because they break it up into groups. So just a horrible qualifying. And normally in the World Championship, if you don't qualify well, you're dead. You don't have a chance. It turned out to be the same case for him. But what's remarkable is that the very next day it rained again, and he did his warm-up and he went P1. P1 means first. First. And so he basically figured out how to drive in the rain, but it was after qualifying, and it was too late, 1 session too late. And he went P1, and he could have basically started he could have started his races in the front row had he had 1 more practice session in the rain, which, you know, is basically asking the impossible of somebody. For those of you who understand motorsports. So, very impressed with his progress, but unfortunately we didn't get a good result this year again. But it's definitely worth going. And he proved to his team and the owner of the team, Dino, Kart Republic team, that he's definitely a serious competitor and contender. So we're going to hopefully race there next year for the European Cup, the European Championship it's called. And if anybody knows any sponsors out there that want to sponsor an American driver, the top American driver, just get in touch with me, because he needs a sponsor. Once you start going to Europe, it starts getting real expensive. What point do you move over there? I would not move over there. I would not let him move over there until he's like driving cars and is on one of the junior drivers for one of the top teams like Ferrari or Mercedes, Red Bull, which we're hoping will be next year or the year after. Until then, we would just fly out there for the races. There's really 6 races in that European Championship, 6 weekends, I should say. So we need to fly out 6 times minimum next year. And each weekend has a double header race, so he literally should be a serious contender. The part of the problem, though, to be quite honest with you, is that the go-kart he's on is actually considered by many to be the best in the dry. But Dino himself acknowledged to me that when there's what are called low grip, where you don't have a lot of grip between the go-kart tire and the track, in low grip situations, the go-kart doesn't behave as well as, say, some of the competition. The competition is quite fierce. Dino's Italian, KR, Kart Republic, is Italian. Dino was the coach for Lewis Hamilton and Nico Rosberg when they were racing go-karts with Zanardi. Dino was their coach, he was their manager. So this guy knows what he's talking about, and he broke off of Tony Kart and basically created his own chassis brand. And the chassis is very good, but let's be honest, it's not as good as the Tony Kart in the wet. And that's why the Tony Karts won first, second, and third in the rain. None of Dino's drivers placed on the podium. So that's something Dino's going to have to go back to the drawing board and figure out how to design a wet kart, maybe a wet model for the wet track that's better, you know. Arias went P1 with that go-kart in the wet in his session. He beat all the Tony Karts. So how he was able to do that after only three 10-minute wet sessions is amazing. It's absolutely remarkable that he could do that. But if we're going to race with KR next year in Europe, we need to know that if it rains, we don't have to run for the hills and hide, you know, and give up our championship bid. I want to know that we have a product that's going to be comparable to the Tony Karts. Tony Kart has dominated the karting world for years, many, many years. It's an Italian brand. It's made in Italy, obviously. The owner's Italian, Robazzi. And he's basically had 90% of the go-kart market in the world for the last 15 years. And now he's being challenged by a competitor, Kart Republic, Dino, who used to work for him. When you can do that. Thank you. There's a piece of herniation right there, by the way, we just took out. So Dino used to work for Robazzi when Hamilton and Rosberg were on the Tony Kart team, on the Zanardi team. And Dino was their manager, basically. Managed their go-karts and the mechanics and everything. So now Dino is taking on Robazzi, the owner of Tony Kart, which is good. And I like Dino. I got a chance to meet him in Portugal last week, and he actually did his best for Arias. So I'm very pleased. He gave him a good engine. He gave him a great mechanic, Rafa, and the whole team is an amazing team. I'm very impressed. But their one weakness, I will say the Achilles heel, right, or the Achilles spot is wet conditions, low grip conditions. And that can be a big problem racing in Europe. So the world champion turned out to be a British driver, Callum Bradshaw. Amazing. I mean, he just drove away in the rain with the win, literally by 8 seconds. 8 seconds is an eternity in racing. Incredible drive. Not a surprise. 1, 2, and 3 were British drivers, basically on an Italian go-kart. All right, we're almost done. This is all scarred up annular tear. We talk about the annular tear a lot, and you can see the golden color is calcium that's inside the tear that's been scarred and healed with inflammation. And unfortunately, it's that inflammation inside the tear that's the cause of the back pain. And a lot of times the leg pain. So I'll reiterate the point. Herniated discs that cause leg symptoms, in my opinion, 95% of the time, the leg symptoms are caused by chemical irritation of the nerve root and not compression of the nerve root. And this is one of the big reasons it's very important for people out there that have back pain, leg pain to understand this. Because your doctor, if he looks at your MRI and sees a small herniation, that doctor is going to tell you there's nothing wrong, that you don't need any treatment. And even though your leg is going to be hurting badly, and it's going to be coming from the herniated disc, the doctor will say it's not coming from the herniated disc when it is. And that's because they don't understand that 95% of the time when people have leg pain from a herniated disc, the herniation is small and it doesn't look impressive on the MRI. It actually is irritating the nerve root through inflammation, not compression. Does that make sense? So it's an inflammatory irritation. Imagine putting bleach on your skin. Nothing is pushing on your skin, but the bleach is irritating, chemically irritating your skin and causing discomfort and pain. That's exactly what inflammation does to a herniated disc. To an annular tear. The herniation causes chemical inflammation and irritation. And that's what causes the leg symptoms and the back pain. So it's one of the big problems in the modern day treatment of back pain is that doctors don't understand the importance of chemical irritation from inflammation. They only see the herniations as being compressive issues, compressive forces, something big pushing on the nerve. No, that's not what causes leg symptoms or back pain. It's not compression. It's chemical irritation from small herniations that does it. And that needs to change. And that's one of the reasons we broadcast our surgeries, so we can educate the public about this, because I try to educate these doctors and they don't listen. They're so stubborn and pig-headed. They have because that's not what they were taught in their residency. It wasn't what I was taught either. I had to learn this on my own. And I learned it by treating patients with smaller herniations, and I saw their pain go away. And I realized it wasn't the size of the herniation that matters, it's actually the inflammation that matters. But that went against the dogma that I was taught as a neurosurgery resident, that all of us neurosurgery residents are taught by our attending physicians, is that it's the size of the herniation. It has to be a big herniation to cause symptoms. And unfortunately, the reason I'm mentioning it is there are millions and millions of people that have curable back pain right now around the world who are living with pain in their back and their leg because their doctor has told them their herniations are not big enough to cause their symptoms. That's a shame that we have to live with that people have to live with that and suffer every single day. Keep your arm up there. Her arm is coming back. She's a little light, which is okay. We're almost done with this disc, but we got one more to do. Yeah, this is the most uncomfortable part of the surgery for the patient, because we've pulled our retractor back to the outer annulus. This is where most of the nerves are in the annulus. And if you don't believe that the annulus has nerves, look at this right here. She's responding to this, and we're in the outer annulus. So, okay? Proof in point.
I have a question.
Yeah.
One of our viewers is wondering, can you do this surgery to a disc that's already been fused but still causing pain?
Can I do this surgery with a disc that's already been fused and still causes pain? I can. I've done that twice now. And the reason I've been able to do it is because I saw that there was a herniation even after a fusion. So the surgeon did a fusion, and there was still a herniation, and I went in and treated it, and the patient got better. I've done it twice. That's not a lot, okay? Two patients is not a lot, but it's enough to convince me that, laser off, that it is possible that people will have, let me have the laser again, that people will have back pain or leg symptoms from a herniated disc at a level that's already been fused because, their surgeon never fixed the herniation while they were in there. Okay, they only fused, and they didn't take care of the herniation. So the answer is yes, but I would never just make that decision without talking to the person first and assessing where their pain's coming from and making sure that anatomically it all lines up properly, you know? I never want to do a surgery on a person that doesn't make them better. So before I do my surgeries, I always carefully assess the patient's MRI. I assess their location of their pain, the quality of their pain, and the physical exam. Sometimes a nerve test called an EMG, nerve conduction study. Actually, most of the time I do look at those. And I want to know for sure that fixing that tear and that herniation is going to alleviate their pain. So before I tell you that reoperating at a level that's been fused by another surgeon is going to help you, I would want to see your MRI, and I would want to interview you through telemedicine, through Skype. That's what we use. And by the way, we do all that at Duke Spine Institute for free. For anyone that wants to do a quick teleconference, we don't charge in 2020. It's all been free. And it's really done to help people, because we understand how hard it is to get an opinion that helps you on your back where you live, because a lot of people don't have access to a doctor that can give them the right diagnosis and cure their back pain. So we do that as a free service at Duke Spine Institute. We're the only place, I think, that does that as a free service. There may be one or two others now that do that. I know that Laser Spine Institute did some of that before they went out of business, but they went out of business over a year ago. Now Duke Spine Institute is the leading endoscopic laser spine center in the world. All right, we're done at L45. We're gonna take all the water out, scope off. Great job. Cam is gonna be leaving us, I heard, and moving on to bigger and better things, eventually medical school, right? But he's gonna be heading over to Tampa. Who are you gonna work for over there, Cam? Huh? Striker. What are you going to do for Striker? Sell things? Yeah. Oh, have you done that before? You know that in sales they don't pay you unless you sell. Come on in. I did lose some weight in Portugal. Hence my lead is like falling off my hips right now. I don't know if you can give me a pull-up. Yeah. Yeah, they don't have an ice box full of tasty treats at 12 o'clock at night that I'm used to. You know, pizza and ham and cheese sandwiches. Yeah, wonderful fish. Actually, we found a really good Indian restaurant called Masala House, and we went there like every other night for their curries and their tandoori. This will be the last disc that we're fixing. Shot. This is the I hope that the needle is still there. Shot. It is. Good. Yeah, you have to keep pressure. There's no joke. All right. We'll get the needle out. Have our guide wire in. Shot. That's it. Good, good. So this will be the last of the discs that we're repairing. And based on her discogram, which we did the test before we started surgery, it actually showed that these 3 discs are causing 10 out of 10 pain, shot, in her back, which means that that pain will be gone. Will you let Dr. Patel know that I'll be done in about 15 minutes? Let me see. Shot. Okay, back, put pressure again. I need that. Not too much pressure while I'm advancing this. Yeah. Shot. How's she doing? Good? Shot. Almost there. Relax. Shot. Shot. Let's get the guide wire out. Shot. Are you there? That's it? Let's advance a little more. Just to make sure. Okay. Shot. Good, good. Yeah. Now I can already tell you folks, this is a very scarred up disc. Okay, how can I tell? Number 1, when I put the needle in. Number 2, when I did the discogram, you could see most of the dye stayed up in the front. That means the back of the disc is massively scarred up from the inflammation from that herniation. And then now trying to go in, I can feel the tear that we're going through in the back of the disc is really scarred. Shot. I want to make sure that my dilator doesn't come out. So I'm going to be taking it nice and slow. Shot. And my dilator is going forward, which is okay. It's not gone too far forward. And I'm going to pull it back just a little bit because it looks like the dilator and the tube are stuck together. Shot. That can happen. It's called, well, it's not really cold welding, but it's when there's a little bit of tissue material that's stuck between the two. Shot. That's probably good right there. So I think we're inside far enough. Yep. Good. Again, the lateral view at this point of the x-ray doesn't really have everything lined up perfectly, but that's okay because you need it when you're putting the needle in. You don't need it as much when you're advancing your dilator and tube. Yeah, I'm ready for you to move out. And remember, she's got bad scoliosis, which we're not treating. We're only treating the herniated discs. When you do a discogram like we did earlier and that we elicited the pain, we were not treating her, we're not testing her scoliosis, we're testing the disc. So it was the disc that caused her pain, if you remember. For those of you that watched this from the beginning, she had 10 out of 10 pain at all 3 discs that we're fixing. And we weren't testing her scoliosis, we tested her disc with a discogram. So we know for sure the discs are the cause of her pain. All right, a little bit of blood clot in there, no big deal. Can we get a little more pressure on the irrigation, or are we maxed out there? That's it? All right. Well, clearly we're inside the disc. You can see the end plate there on the right, and we want to center it. Now this is a very collapsed disc, by the way. There's almost no disc left, okay? Which leads a lot of people to believe, oh, well, how could the disc be the problem if there's no disc left? Isn't it just, I used to believe it was bone-on-bone grinding that caused the pain, but it's not. It's still the same thing. It's the annular tear. It's the same thing that it always is. I'm not able to rotate this very well. Any more questions from our audience?
Not currently.
Not currently. Good. They know everything. Why am I getting so many bubbles? It looks like we got good pressure. Maybe there's suction? No? So once again, it's always going to be the same thing, even if the disc is gone. It's this part right here at the exit of the disc space as you're pulling back. Now I use an inside-out technique, and I apologize for the bad view, folks, but I can't control that. It's not a problem with our equipment. It's actually just a little bit of bleeding coming from the end plate and the epidural space. And there's no way to keep that from happening. It's just going to happen in some patients. But I've been here enough times. I know what I need to look for and do. Standby laser. First time it happened to me 15 years ago, I freaked out. Didn't know what to do. Tried putting a thrombin and waiting and hemostatic, everything. And then I just put my grabber in one day and it stopped. And I realized, just needs a little back pressure, a little hydrostatic back pressure. And that does it. Nice little trick. Well, let's see what we got. Grabber. So I just pull back a little bit more. And then what I'm looking for is this roof right here. This is the tear, the annular tear. This is that part we've talked about so many times. And I'm going to need to get in there with the laser and zap away some of that. Watch it there. All right, we need about 10 minutes max. We'll be done. Yeah, the right RFA. Patel knows, right? All right, grabber. It's interesting. Kind of a really scarred in herniation there.
We have a question.
Sure.
One of yours says, they notice that the bleeding is a little bit more than usual. Is it of any concern?
No. No concern whatsoever. It's more of an inconvenience than a concern. You see where it's coming from right there? That's the end plate. That's like a place where there's a bone spur. Bone spurs tend to bleed once you hack them off because they have the diploic bone in them. Not concerned at all. This is not a lot of bleeding. As I said earlier, if you prick your finger to test for diabetes, for sugar, you're losing as much blood as we're losing on this case, basically. Very minimal blood loss. We're still under 5 mils. So the bleeding itself doesn't concern me. It just makes it more difficult for me to see what I'm doing. That being said, I know where we are, and I'm used to being here. So I feel confident. Let me just get the grabber again. Between, stopping and using the tools to have a better view. The haziness, once again, is just from the bleeding. There. All right, there's the epidural space up there. We're going to clean this up and we should be done. All right, so 5 minutes. And then you're going to take the drapes down, Luis? Is that what you're going to do? And okay. Dr. Patel will come in and do something called a rhizotomy, radiofrequency ablation. She's definitely having pain, not just from her discs, the 3 discs that I fixed, but she's also having pain, in my opinion, based on her pre-op exam, from her facet joints. Why is the laser not working? So all right. That's it. Looks good. Off scope. So we're going to need to put pressure for at least 4 minutes here. Preferably 5. And I'm going to show our viewers the size of the incision. Can you all see this, Sean?
Yes, we can.
Okay, move. Okay, you all see the tube. We're going to bring this out. So the whole surgery was done through a little metal tube. Again, we're putting pressure on the muscles as we always do to keep any bleeding from occurring. And I'm going to show you, once he gets this disconnected, I'll show you the incision. Okay? So we went on the left side of her back because her pain is in the left leg. Her symptoms are in the left leg. So we want to make sure that we address the left side of the disc. If her symptoms were in the right leg, we'd go on the right side. If people have both sides symptoms, we have to go on both sides. But her primary problem was her left toe and leg were numb and tingly, and she was having some weakness on the left side and back pain. All right, are you ready? Here's the incision. So 7 millimeters. It's about the width of half of a dime. Go ahead and put your hand back here for 3 more minutes. We're going to get that closed up and get the RFA done. Good job, everybody. Thank you. Tough case. We did a good job. I mean, a lot of scoliosis makes it always very hard. You got her nice and relaxed, you know, so I could get into the disc space. I'm telling you, if the patient's in pain, you won't be able to get into the disc space because the muscles tighten up and it squeezes the disc together. It squeezes the vertebral bodies down and you won't be able to get in. I've had that in the past. I didn't know why it was happening and I figured it out and now I don't let it happen anymore. So I'll go see the next patient and get them ready. Our next patient will be a Deuk laser disc repair. I'm going to come in and answer questions for you guys about this surgery or anything else you have related to spine. Go ahead and type them up and I'll come over there and I'll answer them for you in about 5 minutes. So just stick with us, okay?
All right, everyone, thank you for joining us for the post-op Q&A. We have Dr. Duke in the room with us here. He's about to come in and answer some of your questions that we have still. Just to give you a quick rundown of the surgery you just watched a 3-level Duke laser disc repair all on the right side. That was done to alleviate a herniated disc at those 3 levels as well as the annular tear. This patient will be up and ready in about an hour. She's getting an RFA done now as well at those same levels to alleviate facet joint pain. So she'll be in the OR a little bit longer, but while we wait for her to come out and for the next patient to come in, we have some questions coming up for you. The first of which comes from a viewer on Facebook who asks, how does Duke laser disc repair help degenerated discs?
Thank you, Sean. And it's good to be back, first of all, back in Florida, back to work. Not that I was out of work, but I was in Portugal for 2 weeks with Arias and competing in what's called the World Championship of go-karting. This is called the CIK FIA World Karting Championship 2020. And now I'm back, and it's great to be back taking care of patients, which is my greatest passion in life. And our patient we're just finishing up with comes to us from Texas. They don't have the Duke laser disc repair in Texas. It's only available in Florida right now at Duke Spine Institute. And you know, the question we're getting from our Facebook viewer is, does this work for degenerated discs, and what's the difference? So I'm just going to review briefly disc injuries, and I want you all to have a good understanding when I'm done that disc injuries are basically all pretty much the same, and they all start with trauma or an injury to the disc, usually in the form of over-compression of the disc or over-distraction of the disc or over-rotation of the disc. So let me clarify what I mean by that. The spine itself is made up of bones stacked on top of each other, and in between those bones are joints. Just like your elbow joint, your wrist joint, your knee joint, joints are places where 2 bones come close together and there's movement in a space between the bones, and that space isn't just air, it's actually very sophisticated tissues, mostly connective tissues. And in the case of the spine, you have 2 types of joints between the bones. In the front of the spine, you have a disc. In the back of the spine, you have a facet joint. Now, every 2 bones that come near each other in the spine have 1 disc that they share. It's like a giant cushion. It's not circular and not really oval shaped. It's kidney shaped, if that makes sense. If you look at a kidney bean, it has the shape of a kidney bean. And the facet joints are the second type of joint, and there are 2 of them. So for every disc, there are 2 facet joints behind the disc, 1 on the left, 1 on the right. So for example, let's take the L4 bone and the L5 bone, all right? That's called the L4 vertebrae and the L5 vertebrae. Now between these 2 bones are 1 disc and 2 facet joints. The disc is called the L45 disc, and the facet joints are called the left L45 facet joint and the right L45 facet joint. Now let's focus for a moment on the disc itself. The disc is actually a joint where between the 2 bones is a giant pad, and in the center of that pad is something called the nucleus pulposus. It's a watery material that is a great shock absorber, and it really is kind of clumpy and sticky, and it stays in the middle of the disc. Around the nucleus pulposus is a very, very tough connective tissue made out of collagen, which is used throughout your body in many places, called the annulus fibrosus. And the annulus fibrosus is rings, much like the rings of an onion, except the center of the onion is filled with the jelly. So you have 20 to 25 concentric rings of annulus fibrosus, and in the center you have the jelly called the nucleus pulposus. Now what happens with all disc injuries is that the person who has a disc injury does something to injure their disc. And usually it's a loading of the disc, an excessive loading or excessive rotation, or excessive distraction. So very common, for example, car accident. You're sitting in your seat, driving, and you rear end somebody. Your whole body, your whole upper body goes forward, and the seat belt and the seat hold the lower body on the seat. So now your disc tears in the back of the disc because it's leaning forward and it's stretching the annulus fibers and beyond the point of that they're able to hold, and they start to rip. So you get a tear in the annulus, and then you get any kind of lifting or bending or twisting pressure on that disc is going to squeeze the nucleus material. The jelly that's in the center is going to squeeze out through that new tear. And once it starts squeezing out and gets wedged in there, it creates inflammation. And that's where the Deuk laser disc repair, of all surgeries on the spine available in the world, we're able to go in and see that tear, see the jelly wedged in there, and remove that jelly and clean the tear up so it heals properly. That's what the Deuk laser disc repair is about. Now, what is a degenerated disc? A degenerated disc is the same as a herniated disc, but degeneration starts the moment you have a herniation, and it continues throughout your entire life. So a degenerated disc is really just a disc that has had an injury to the annulus fibrosus, and it starts to lose the jelly inside because it dries out and squeezes out through the tear, and the disc starts to collapse. So the degenerative process, or degenerative disc process, starts the moment you get an injury to the annulus fibrosus, and it ends the day you die. And it never stops throughout your whole lifetime. Once you've injured the disc, it's an ongoing process. So what is a degenerated disc? It's any disc along that process continuum. There's no single definition of a degenerated disc. It's basically a disc that isn't normal, and it starts to lose the water content of the nucleus, so it gets dark on a T2 weighted MRI, and it starts to lose its height. So does this laser surgery work for degenerated discs? 100%. Yes, it does, for all degenerated discs. As a matter of fact, the last disc I just did in the surgery, the L34, was the most degenerated of all three, and it was almost basically bone on bone, with just a tiny little bit of annular tear with interposed nucleus that I used the laser to zap away, and that will fix her back pain. Here, Sean, for the next question.
Our next question comes from another viewer on Facebook who asked, does osteoporosis change the outcome of this surgery?
All right, another viewer has asked, Dr. Deukmedjian, does osteoporosis change the outcome of the surgery? The answer is no, it doesn't. And let's just look at why. Osteoporosis is a condition that affects bone and basically weakens bones as the bones are dissolved away over time, usually a long period of time of many, many years, not just days or months, but years. And it's usually due to an imbalance of hormones in your body, where the imbalanced hormones have an effect on little cells that live inside your bones called osteoblasts and osteoclasts. Now, osteoblasts are cells that make bone and make your bone stronger. Osteoclasts are cells that dissolve your bone and make them weaker. So what happens is your bones are constantly, throughout your life, from the day you're born, they're constantly being taken down and built back up, taken down, built up, taken down, built up, instantaneously, constantly, all the time. From the moment you're born to the moment you die, your bones are remodeled, okay? We call this remodeling process, where bones are dissolved in some places and rebuilt in others. Now, the key is that you want the dissolving and the rebuilding process to basically be balanced out, to where the dissolving of the bone happens in order to release free calcium into your bloodstream, because you need your calcium levels to be constant for your muscles to contract and your heart to contract properly. And then bones are being rebuilt, and you want the dissolving and the rebuilding, so the releasing of calcium and the taking back of the calcium into the bones, to be a balanced process, and hormones regulate that. When you have hormonal irregularities and hormones aren't being produced either by your ovaries or by your testes so much anymore, then there becomes an imbalance in this hormonal milieu throughout your body, and you get an imbalance in the breakdown and the buildup of bones, to where it favors breakdown. As this happens over years, your bones get weaker and weaker and weaker. And eventually you can have fractures of those bones. They're called insufficiency fractures because you have insufficient bone to prevent the fracture from happening. It's kind of like a piece of wood that gets rotted out over years. Eventually it's going to crack and break under the weight. So, you know, what may be normally a very good piece of wood to hold up the weight of your house eventually will get destroyed with wood rot, and it gets weaker over time, and it cracks and breaks, and then the house falls apart. So osteoporosis is a weakening of bones. What we do the surgery, the Duke laser disc repair for, is not osteoporosis. We do it for problems with the joints between the bones. So we're repairing a bad joint. We're not doing anything with the bones themselves. The bones themselves aren't the problem. Now, she does have osteoporosis, and she does have fractures from osteoporosis, but that's a completely different problem, and we've already treated that with a kyphoplasty where we put some cement inside her spine to strengthen those bones. So the surgery we just did now, the Duke laser disc repair, is for a bad joint called the disc, a disc injury or a disc herniation, whereas osteoporosis affects the bones themselves and causes fractures of the bones, which she does have fractures as well, and we've already treated those. I hope that clarifies the issue.
And our next question is, how severe does scoliosis have to be before DLDR is no longer an effective option?
So one of our viewers is asking about the scoliosis, and they said, how severe does scoliosis have to be before Duke laser disc repair is not an option? That's a great question. So let's get back to this because I addressed it a little bit earlier. People don't come in to the doctor's office complaining of scoliosis. It's extremely rare they would come in and say, my spine is twisting, fix it. What people complain about is back pain. What people complain about is leg pain or symptoms going down their leg from pinched nerves. So nobody comes in to the doctor and says, my spine is twisting, fix it. I have no symptoms, no pain, no symptoms whatsoever. My spine is just twisting, fix it. We don't do surgery for that. We do surgery because the spine is twisting and people have pain. What I'm telling you is that all the spine surgeons that treat scoliosis, which I do as well, using what's called fusion, what's called derotation, basically correction of deformity surgery, where we go in and twist the spine back so it's straight and put in screws and rods to hold it there. That type of deformity surgery where we go in and fix the scoliosis, where we fix the listhesis, where we fix the kyphosis, these are all different kinds of deformity of the spine, which means abnormal alignment is the right way to say it, abnormal alignment of spine. Deformity surgery to fix the abnormal alignment of the spine, such as scoliosis, kyphosis, and listhesis, those types of surgeries, I'm telling you, are completely unnecessary 99% of the time in adults with adult onset scoliosis. That's degenerative scoliosis. And the reason they're unnecessary is that all the surgeons that do these surgeries are treating pain, back pain, or pinched nerves. And what I'm saying is we can fix the back pain that's associated with scoliosis, kyphosis, listhesis by repairing the herniated disc and not derotating or correcting the alignment of the spine. The spinal alignment does not need to be corrected to get rid of the back pain or the neck pain, if it's in the neck, or the irritated nerve pain. Okay, it can all be done with the Duke laser disc repair, as you've watched. So I can say this because I've treated literally thousands of patients with scoliosis. And in the last 15 years, I've cured all of their pain, the people who have scoliosis, kyphosis, listhesis, by just doing a Duke laser disc repair on their herniated disc. So what I'm getting at is back pain associated with scoliosis, kyphosis, listhesis is not coming from the scoliosis, kyphosis, listhesis because I'm not fixing the scoliosis, kyphosis, listhesis. I'm repairing the tear in the back of their disc. That's what I'm trying to tell everybody, so you understand that the deformity does not need to be fixed to get rid of the pain, and the patient comes into the doctor's office because of the pain. So we're basically over-treating tens of thousands, if not millions of patients around the world every year with scoliosis, kyphosis, listhesis by doing open back surgery with fusion and derotation and correction of deformity surgeries, which I've done over 1,000 myself in the back. So I know how to do these surgeries. I've done many, many of them, and they do work. But it's not necessary. It's over-correcting. It's over-treating the patients when they could be fixed with their back pain and their leg symptoms by just doing the Duke laser disc repair procedure. That was our last question, and I'm going to go check on the next patient. We're going to be doing an L45 Duke laser disc repair in a gentleman that has back pain from a herniated disc at L45.